Imagine a person living with severe body integrity dysphoria. They seek medical help repeatedly. They explain their suffering, undergo assessment, and pursue every recognized avenue available to them. Amputation is refused, and no effective alternative pathway is offered. The person later injures themselves in an attempt to achieve what medicine would not provide. Who bears moral responsibility for what happened? The patient performed the act. That establishes direct causal responsibility. It does not settle the moral question. Did the refusal contribute to the circumstances in which the act occurred? Did the institution have a responsibility to provide support, further assessment, or a safer pathway? And how should responsibility be divided when one person acts within a situation shaped by decisions made by others? That is the question we examine today. The framework we developed in the previous episode asks us to examine the conditions surrounding the action, the person's freedom, the pressures they faced, the alternatives available, and the decisions made by others along the way. The argument I develop here follows that question into difficult territory. Its purpose is not to excuse or glorify self-injury. It is to examine whether an institution that refuses medical help, offers no effective alternative, and knows that some patients may later place themselves in danger, can remain entirely outside the moral account of what follows. The patient's responsibility does not necessarily disappear. The institution's responsibility may still need to be considered. Once we separate the person who performed the act from everyone who shaped the circumstances around it, the familiar answer to who is to blame becomes far less secure. This is Contested Bodies. I'm Leandro, Loriga. Welcome to episode 9, Who is to Blame? Today, we follow the framework of moral responsibility into a real and difficult clinical situation. Before we begin, I need to give a brief content warning. This episode discusses self-harm and self-amputation. I will refer to these events because they are central to the question of responsibility. I will not describe methods or present the action as admirable, inevitable, or desirable. Listeners who may find this material difficult should feel free to skip the episode or return to it at another time. In episode 8, we built the framework of moral responsibility. We defined reactive attitudes as the emotional and moral responses through which people hold one another answerable: blame, resentment, gratitude, indignation, forgiveness, and praise. We examined blame and the assumptions that may support it, including improper motives and culpable ignorance. We distinguished coercion, which usually involves serious external pressure or threats, from compulsion, an internal urge that may make resistance difficult. And we used Harry Frankfurt's work to challenge the idea that responsibility always depends on having been able to produce a different outcome. Today, we apply that framework to BED. 3 questions guide the episode. First, does the desire for amputation reduce the patient's control enough to limit their moral responsibility? Second, when a physician suspects deception, ignorance, or impaired judgment, what evidence supports that suspicion? Third, how do the physician's own assumption, professional constraints, and understanding of the proper body influence the refusal? The argument will lead us towards distributed responsibility. The patient acted, the clinician refused. The institution defined what care was available. The surrounding medical culture shaped which bodily outcomes could even be considered. Our task is to identify what each party can fairly be held answerable for. We begin with the patient's desire and the question of whether it functions as coercion or compulsion. The first question is whether the desire for amputation significantly limits the patient's freedom and control. We need to be precise about the language. Coercion usually involves pressure imposed by another person, a threat, force, or circumstance deliberately used to make someone act. An internal desire is better described as a possible compulsion. A compulsion is an urge that becomes difficult to resist and may narrow the person's ability to reflect, delay action, or choose another course. If the BD desire completely overwhelmed rational control, that could reduce the patient's moral responsibility for actions taken under it. It would not automatically eliminate responsibility. We would still need to ask how much understanding, reflection, and control remained. Some early description of BID used language that suggested this kind of overpowering force. Greg Firth and Robert Smith were among the early writers who documented the experiences of people seeking amputation. Writing in 2002, they described cases in which the desire could suddenly reach great intensity and leave the person feeling unable to regulate it. That description resembles compulsion. The current diagnostic language is more restrained. ICD-11 describes BID as an intense and persistent desire to become physically disabled in a significant way. Intensity tells us how powerful the desire may be. Persistence tells us how long it lasts. Neither term establishes that the person has lost the capacity to reflect upon it. Clinical accounts often describe people with BID as lucid, articulate, and aware of physical reality. Many have examined the desire over years or decades, sought information, considered alternatives, and developed detailed accounts of why the affected limb feels incompatible with their bodily identity. That brings us to another possible comparison. Is BD an obsession? In psychiatry, an obsession is a recurrent thought, image, or impulse that enters the mind unwanted and causes distress. The person commonly experiences it as alien to their values or wishes. A compulsion is a repeated action or mental ritual performed in response to that distress, often according to rigid rules. For example, someone may experience an intrusive fear of contamination and repeatedly wash their hands to reduce the anxiety. BID usually has a different structure. The unwanted element is often the existing bodily configuration rather than the desire for change. The person may wish they had never developed BD and may desperately want a life without the conflict. Yet the belief that a particular limb does not belong within their proper bodily form may remain integrated into their sense of self. The desire can therefore be distressing without being experienced as an alien thought that the person rejects. ICD-11 does not classify BID as an obsessive-compulsive disorder, and compulsion is not part of its defining description. That does not prove that every patient retains complete control at every moment. The intensity may rise and fall. During periods of acute distress, reflection and self-control may weaken. The broader evidence, however, does not support treating BID as an overpowering compulsion by default. The appropriate question is individual. Can this person step back from the desire, reflect upon it, tolerate delay, understand the consequences, and choose how to respond? For many people with BID, the available accounts suggest that the answer may be yes. If BID is not an obsession in the psychiatric sense, how should we understand the persistence of the desire? Consider someone living with chronic, debilitating migraines. Over many years, they may become intensely focused on finding relief. They research treatments, consult specialists, monitor symptoms, and think frequently about how to escape the pain. From the outside, that persistence may appear obsessive. Within the person's experience, however, it may be an understandable response to continuing suffering. The repetition of a desire does not by itself make the desire irrational. The same distinction may apply to BID. A person may think repeatedly about amputation because the bodily conflict repeatedly returns. Their attention remains fixed on relief because the distress remains unresolved. This does not prove that the desire is rational in every case or that every proposed response to it is justified. It does mean that persistence alone is not evidence of compulsion or impaired judgment. The intensity may also change over time. I describe it as moving like a wave. At its peak, the distress may narrow attention, increase urgency, and weaken the person's ability to reflect calmly. At lower points, the person may be able to examine the desire, consider alternatives, and reason about the consequences with greater distance. Fluctuating intensity does not necessarily make the underlying desire alien or irrational. Many forms of chronic pain and psychological distress rise and fall while remaining intelligible to the person experiencing them. The available evidence, therefore, does not support treating the BID desire as an overpowering compulsion by default. Many patients appear to retain the ability to reflect, delay action, seek information, and explain their reasons. Their rational agency may be pressured by distress without being erased. That keeps the question of moral responsibility open. If the patient is still being treated as blameworthy, what exactly is the alleged fault? Is the physician assuming an improper motive, or are they assuming that the patient does not understand what they are asking for? Those are the two roots we examine next: ill will and ignorance. The first possible basis for blame concerns deception. The suspicion is that the patient is not presenting their true reason for wanting amputation. They say they seek relief from bodily dysphoria, while the clinician suspects another motive underneath: sexual arousal, attention, financial benefit, or some other form of personal gain. This is what I call the deceiver hypothesis. Some surgeons found the stated explanation so difficult to accept that they assumed another explanation must be hidden beneath it. Historically, the most influential hidden motive account was sexual. Under that interpretation, the patient's account of bodily mismatch could be treated as a facade concealing the true motive. We need to distinguish three things carefully. An unusual motive is not necessarily an improper motive. A sexual element where present does not automatically invalidate the wider experience of BID. Deception becomes morally relevant when the patient knowingly conceals information that the clinician reasonably needs in order to assess the request safely. A doctor cannot evaluate risks, expectation, or capacity properly when important information is deliberately withheld. Where deliberate deception is established, criticism may be justified. The crucial word is established. The question is not whether some patient somewhere might present dishonestly. Deception occurs across medicine for many reasons, including fear, shame, substance dependence, financial gain, or a desire to obtain a particular treatment. The question is whether the particular patient being assessed is deceptive. That requires evidence. Suspicion cannot be inferred from the diagnosis itself. The wider literature also supports a heterogeneous picture. Some people report a sexual component. Others do not. For some, sexuality may coexist with a persistent experience that the limb does not belong within the body they recognize as their own. The evidence, therefore, does not justify treating every BID patient as a deceiver whose account of suffering conceals a sexual motive. The burden lies with the clinician to identify evidence of dishonesty in the individual case. Without that evidence, the deceiver hypothesis remains a preconception rather than a justified basis for blame. If deception cannot generally explain the skepticism, another possibility remains: the belief that the patient does not truly understand what they are asking for. That brings us to ignorance. The second possible basis for blame is ignorance. The patient may be acting honestly, yet the clinician believes they do not fully understand what they are asking for. The assumption is often simple: if this person truly understood amputation, they would not continue to want it. Ignorance does not mean stupidity. It means lacking information or understanding that is relevant to a decision. The moral question is whether the person can fairly be blamed for what they did not know. A philosophical analysis published by Fields in 1994 draws on an older distinction between two forms of ignorance. The first is ignorance of general moral principles. A person may not understand what they are ordinarily expected to do or avoid. They may fail to recognize that deception, recklessness, or avoidable harm is morally wrong. The second is ignorance of particular facts. A person may understand the general rule while lacking information about the specific situation. Imagine someone giving another person food without knowing it contains an ingredient to which they are severely allergic. They understand that causing avoidable harm is wrong. They do not know the particular fact that makes this action dangerous. Ignorance can reduce responsibility when the person had no reasonable way of obtaining the missing information. It may not excuse them when they ignored an obvious risk, refused available information, or failed to make inquiries that their role required. The key question is whether the ignorance was itself avoidable. Fields also places considerable weight on intention. An action can produce harm while the person performing it sincerely believes they are doing the right thing. That intention affects how we judge them. Someone who knowingly causes harm is judged differently from someone who acts with good intention but makes a mistake. Good intentions do not settle the question. A well-intentioned person may still act negligently, recklessly, or without sufficient concern for foreseeable consequences. Blame, therefore, depends on several factors. What did the person intend? What did they understand? What should they reasonably have known? What opportunities did they have to learn more? And how carefully did they consider the possible consequences? Applied to BED, the question is not whether the patient possesses perfect knowledge. No surgical patient does. The question is whether they understand enough about amputation, disability, rehabilitation, phantom pain, and permanent functional change to make a responsible decision. If important knowledge is missing, we must then ask why. Did the patient ignore information that was available? Or has medicine failed to develop and communicate the evidence they would need? That distinction determines whether ignorance can fairly support blame. Let us see now how this applies to BD. First, general understanding. A carefully assessed patient may understand that amputation is irreversible, that it removes healthy tissue, and that medicine regards the request as highly unusual. They may also recognize the moral conflict involved. Their claim to bodily autonomy stands against the clinician's duties to preserve function and avoid harm. Their intention is usually described as relief from persistent bodily distress. That intention is relevant to moral judgment. It does not, by itself, establish that the decision is correct or free from risk. Then come the particular facts. Does the patient understand phantom limb pain, rehabilitation, prosthetic use, reduced mobility, possible dependence on others, the effects on work, relationships, and ordinary daily life? Knowledge may be incomplete in any individual case. Surgical patients are not expected to arrive with the expertise of clinicians. Informed consent exists because medicine has a responsibility to explain the diagnosis, the intervention, the risks, the alternatives, and the areas of uncertainty. There is therefore an information imbalance between patient and professional. The patient must engage honestly with the information provided. The clinician and healthcare system must make adequate information available. With BED, that process is difficult because the evidence remains limited. The causes are contested. Treatment pathways are poorly developed. Long-term surgical data are scarce. Specialist services are largely absent. Some uncertainty, therefore, arises from the condition-limited evidence base rather than from negligence by the patient. That does not remove all personal responsibility. A patient may still ignore warnings, conceal relevant information, reject assessment, or underestimate consequences. The point is that missing knowledge cannot automatically be blamed on the patient when medicine itself has not produced clear answers. Responsibility must therefore be assessed in degrees. A patient acting in good faith, engaging with assessment, and seeking to understand the consequences may bear responsibility for the decision they make. The medical system also bears responsibility for the quality of the information, support, and alternatives it provides. The question is no longer whether the patient is entirely responsible or entirely excused. It is how responsibility should be distributed when both personal choice and institutional uncertainty shape the decision. We now return to the principle of alternate possibilities. A person's responsibility may be reduced when their available choices are severely restricted. That does not mean they literally have no alternatives. It means that the alternatives may be inaccessible, ineffective, or accompanied by serious suffering. Consider the position of a patient with BID after amputation has been refused. Several paths may remain. The first is to continue living with the existing body while managing the dysphoria as far as possible. That may involve psychotherapy, medication for associated anxiety or depression, peer support, disability simulation, or strategies for reducing distress. These approaches may help some people cope. Current evidence does not show that they reliably remove the central desire. The second path is to continue seeking professional help. The patient may request another assessment, consult a specialist, participate in research, or pursue treatment in another healthcare system. For many patients, however, no recognized surgical pathway exists. Repeated consultation may lead to the same refusal. The third path is dangerous action outside medical care. Some people with BID have injured themselves after being unable to obtain treatment. These cases have resulted in severe complications, emergency surgery, and, in some instances, death. This is not a treatment option. It is evidence of what may happen when severe distress persists and no acceptable pathway is available. The patient therefore retains alternatives, but their quality matters. One path may involve continuing distress. Another may offer repeated assessment without an available intervention. A third creates grave and immediate danger. This is a severely constrained choice rather than a completely coerced one. Institutional refusal does not directly force the patient to harm themselves. The patient remains an agent whose actions require moral evaluation. The institution may still bear responsibility for the conditions surrounding that action. The absence of specialist care, limited evidence, inadequate support, and the failure to develop safer responses. The question is therefore wider than whether the patient could physically have done something else. A dangerous path outside medicine may then begin to appear possible. I have argued that this situation creates a form of structural pressure. It is not coercion in the strict sense. No clinician is threatening the patient or directly forcing them to act. The institution still shapes the available choices. When a healthcare system recognizes a condition, knows that severe distress and self-injury can occur, yet offers no effective treatment pathway or adequate harm reduction response, it contributes to the condition under which desperate choices are made. That contribution does not erase the patient's agency. It changes the moral context in which the action must be judged. The question is therefore no longer, did the patient have any alternative at all? The better question is, did the patient have a meaningful, tolerable, and clinically supported alternative? When the answer is uncertain, responsibility cannot be assigned to the patient alone. We must also examine the clinicians, institution, and policies that determined which forms of help were available. The argument now reaches its most provocative conclusion. A person may deserve praise when three conditions are present. First, they sincerely intend to do what they believe is right. Second, they act according to that intention. Third, they overcome a powerful inclination to act differently. Now, apply that framework to the particular case we have constructed. The patient lives with severe and prolonged suffering. They have sought medical help in good faith. The recognized system has refused the intervention they believe would relieve that suffering while offering no alternative that addresses the central dysphoria. They then act according to what they understand as necessary for relief, despite having to overcome the ordinary human impulse towards bodily self-preservation. If we accept those premises, a disturbing proposition follows. The action may qualify as praiseworthy within that specific moral framework. I want to be precise about what kind of claim this is. It is a conditional philosophical conclusion. It says, if the patient sincerely believes the action is necessary, if the available alternatives have become severely restricted, if the intention is relief rather than deception, recklessness, or harm to others, and if acting according to one's perceived duty while overcoming a powerful contrary inclination can merit praise. Then the framework appears capable of classifying the action as praiseworthy. This is not a general endorsement of self-amputation. It does not claim that every person with BID acts under these conditions. It does not establish that the action is medically safe, ethically required, or something others should imitate. The proposition concerns what follows from a particular set of premises when a particular theory of praise is applied consistently. Its force lies in the discomfort of the conclusion. A medical system has created, or at least helped sustain, circumstances in which a desperate and dangerous action can become morally intelligible, and under one philosophical framework potentially praiseworthy. That conclusion should direct our attention back towards the institutional situation. The purpose is not to celebrate the act, it is to expose the moral consequences of recognizing severe suffering while providing no adequate clinical pathway. If the framework leads us to a conclusion this troubling, the response cannot simply be to condemn the patient and leave the surrounding conditions untouched. Taking no position is not neutral. Refusal also shapes the moral landscape in which the patient acts. I want to slow down here and explain exactly what this argument is doing. It is a philosophical reductio. A reductio accepts a set of premises provisionally and follows them to their logical conclusion. When that conclusion becomes disturbing or difficult to accept, the argument exposes a serious problem in the original situation, the premises, or the way they have been applied. If the reasoning leads to the possible praiseworthiness of severe self-injury, then the surrounding situation demands scrutiny. The provocation directs moral attention towards the institutional response. I conclude the argument with this proposition. This dynamic places individuals with BID in a difficult position, emphasizing the urgent need for less destructive treatment options. Taking no definitive stance in this context cannot be considered the least harmful solution. That is the central conclusion. The argument calls for less destructive treatment options and a serious clinical response to recognized suffering. Institutional inaction is still a decision. Refusal changes the patient's remaining possibilities. It may contribute to the condition under which desperate actions occur. Those consequences belong within the moral assessment of the patient, the clinician, and the institution. The conditional claim of praiseworthiness is therefore an indictment of the situation that makes such a conclusion philosophically possible. Let me step back and place today's argument within the season as a whole. We began with a historical asymmetry. Gender dysphoria developed through decades of research, activism, clinical practice, and theoretical debate before entering recognized medical pathways. BID followed a different history: limited research, persistent skepticism, changing diagnostic language, and only recent formal recognition in ICD-11. We then examine embodiment, the comparison with gender dysphoria, the 4 principles of bioethics, and Frankfurt's account of desire. In episodes 6 and 7, we entered the consulting room. My fieldwork showed that the principles professionals cited did not always fully explain the decisions they reached. Body harmony, paternalism, and the selective application of risk and certainty shaped which bodily requests appeared legitimate. Autonomy began to function as a property of the intention rather than of the person. A patient could be treated as autonomous until they wanted a body medicine found unacceptable. Episode 8 gave us the framework of moral responsibility. We examined reactive attitudes, blame, improper motives, culpable ignorance, coercion, compulsion, and Frankfurt's challenge to the principle of alternate possibilities. Today, we applied that framework. The BD desire does not appear to eliminate rational agency by default. Many patients can reflect upon it, seek information, delay action, and explain their reasons. The general presumption of deception is not supported simply by the diagnosis. Where knowledge is incomplete, some of that uncertainty arises from medicine's limited evidence, undeveloped pathways, and failure to provide clear information. The patient cannot fairly be blamed for failing to possess knowledge that the medical system has not yet produced. Refusal then changes the structure of the patient's choices. It does not literally force a later act. It can leave the person under severe structural pressure, continuing distress, repeated assessment without an available intervention, or dangerous action outside medical care. The institution therefore enters the moral account. The patient remains answerable for what they do. The clinician remains answerable for the assessment, the refusal, and the support offered. The institution remains answerable for the pathways it creates, the knowledge it develops, and the risk it leaves unaddressed. Responsibility becomes distributed. The final proposition is deliberately unsettling. Under a specific set of premises, and within Fields' theory of praise, an act of self-amputation may become conditionally classifiable as praiseworthy. The person acts according to what they sincerely understand as necessary while overcoming the powerful impulse towards bodily self-preservation. That is a reductio. It does not endorse the act. It exposes the moral situation in which such a conclusion becomes philosophically available. If the proposition appears scandalous, the scandal lies in the circumstances that produced it. Recognized suffering, restricted alternatives, institutional refusal, and the absence of a less destructive clinical response. That is where the season has been heading. The moral picture is now more complicated than the familiar story in which the patient acts and therefore carries the entire burden. The bid desire does not automatically remove rational agency, nor does the request by itself demonstrate deception, ignorance, or impaired judgment. Where the patient lacks information, some of that uncertainty may arise from medicine's limited evidence and undeveloped treatment pathways. Refusal then changes the circumstances in which the patient must act. It does not literally force self-injury. It may create severe structural pressure by leaving the person with persistent suffering, limited support, and unrecognized intervention addressing the central dysphoria. Responsibility therefore becomes distributed. Taking no definitive position is not necessarily the least harmful option. Refusal also shapes what follows. A profession that officially recognizes the suffering associated with BID must confront the request on its merits, develop safer forms of care, and accept that institutional inaction carries moral consequences of its own. Across episodes, we have examined the history of BID, bodily identity, justice, autonomy, clinical decision-making, risk, responsibility. The next episode brings those strands together and asks what medicine would need to change if it were to respond to BID consistently, honestly, and safely. And with that, we've reached the end of the road, at least the end of the arguments. This was the last thematic episode of Contested Bodies for this season. Over 9 episodes, we've moved from history to theory, from the clinic to the philosopher's desk, how a condition came to be named, how medicine decides what counts as legitimate suffering, who gets to decide, who gets blamed, and what it even means to be healthy. Each episode stood on its own, but they were always building toward the same question: who has the final word over the body? I'm not going to answer that question today. That's deliberate. In episode 10, the final episode of the season, I'll step back from the material and do something different. No new cases, no new frameworks, just observations. What I think this condition reveals about medicine, about institutions, and about all of us, whether or not we've ever heard of it before this season. Some conclusions, some open questions. If any of the topics we've discussed this season have touched you personally, remember that support exists, and reaching out to a professional or someone you trust is always a legitimate first step. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I will see you one last time in the season final episode. If you enjoyed this episode, please share it and follow Contested Bodies wherever you listen. Contested Bodies is independently written, produced and hosted by me, Leandro Loriga. The podcast receives no institutional funding or external financial support. This initiative was born from a desire to make invisible lives visible and examine the gray zones of medicine and the human condition. You can support the research, production, and future episodes through the donation link in the description. I'm Leandro Loriga. This has been Contested Bodies. Thank you for listening. I'll see you next time.